Hello. Um, I'm Hansel Otero. I'm a pediatric radiologist at the Children's Hospital of Philadelphia. And today we're going to be visiting indications for brain ultrasound that are outside of the most common indication for brain ultrasound, that is germinal matrix hemorrhage in premature babies in the neonatal ICU. So we're going to go through some of the indications, some of the findings, and the interpretation kind of um, all but um, premature germinal matrix hemorrhage. Just to start, let's start by listing some of the advantages of ultrasound. We know it's a preferred modality in the neonatal brain. It's non-invasive, safe, it doesn't require radiation, is widely available, and easily accessible. It's also portable, so it can be performed bedside. It's less costly than the other imaging modalities available to image the brain. Doesn't require sedation, anesthesia, or actually it doesn't require immobilization either. And as important is that it can be repeated over time to see brain maturation or the evolution of and follow up of lesions. In terms of technique, we're going to use two different transducers. One is the traditional brain probe, that is a sectorial probe, and then the high frequency linear probe that give us more detail but less penetration, so we can know and can get a lot more detail of those superficial structures, sacrificing a little bit like the penetration into the posterior fossa, for example. Um, Even though we can use different windows, most of the images, the great majority of the images I'm going to show you today, are performed from an anterior fontanelle. If and when the images that I'm showing you are obtained through the mastoid fontanelle, I will let you know. The anterior fontanelle closes in most kids between 9 and 15 months, but that's why but I don't want this to become like a hard stop. In reality, if the anterior fontanelle is open, we can get a brain ultrasound. What can be diagnosed with brain ultrasound? Well, we can diagnose hemorrhage. We can certainly see the size and the configuration of the ventricles. We can see findings of ventriculitis or infection in general, mass lesions, congenital malformations, and some skull or scalp lumps and bumps. Um, what I think brain ultrasound is really useful for is to determine the need for CT and MR in places where access to CT and MR is limited. So it can be preferred to CT because it doesn't have radiation. It can be as a screening test for deciding MRI in places where MRI is not available and require transfer of the patient to a different facility, for example. In terms of the technique, you see how the probe goes in the anterior fontanelle, and then we find, in this case, in the coronal plane, and you see what how we're going to image the brain that way. This animation, it also tells you which structures are, or how we start missing some of the parenchyma as the fan, the beam of the ultrasound goes anterior to posterior, but you can miss some of that parenchyma when the fontanelle starts to close. Same goes for sagittal imaging. Again, the probe goes um, on the anterior fontanelle, and we're going to fan from side to side and obtain those sagittal images. These are just some examples in coronal plane of how normal looks like. So we go from 24, 32 weeks to 39 gestational age, and this is how they look with increasing gyration and differentiation between the gray and white matter. For term babies, we do see that, again, we see most of the brain at 0 months, and as the fontanelle gets increasingly smaller as it starts to close, we start to miss more and more parenchyma, and we only see kind of the central structure. Moving on to see some of the cranial pathology that we can determine in ultrasound. A lot of our referrals in the outpatient setting are for macrocephaly. These are babies that just have their regular well child visit. They get a head circumference measure, and they are in the 95th percentile or above. This case is an 18-month-old, but you see that, again, that we can clearly see that those ventricles are not markedly dilated, and the extraaxial spaces are not dilated either. So a lot of these patients don't require extra imaging. We stop the workup right here. This is another 18-month-old. You see that we can see more brain because the fontanelle is a little bit more open in this baby. And you do see in this case that the extraaxial spaces are enlarged, or are larger than in the previous case. So this is a case of benign enlargement of subarachnoid space in infancy. Again, this baby doesn't require extra follow-up or extra imaging. Different than this 27-month-old with known hydrocephalus and new headache. Again, there is marked dilatation of the ventricles. There is also dilatation of the extraaxial spaces because there is overall kind of atrophy. And this is just the correlative CT from a couple months before the ultrasound. This is a patient that was awaiting BP shunt placement, had sepsis, and was in the hospital for a long time. And you can see that they were alternating evaluation with ultrasound that can be done bedside and more often. And we see the degree of dilatation of the lateral ventricles. Again, very similar to the coronal CT, and again, following up with ultrasound. This is a baby with sepsis, and in this case is a premature baby. You see the simplification of that brain parenchyma, but you see the increased echogenicity and the septations within the lateral ventricles, all these complex septations and thickening of the ependymal lining that tells you that he has ventriculitis. This baby went, the diagnosis is meningoencephalitis, and these are the images from MRI a week later, and you see that there are already brain abscesses. So again, ultrasound gives you the diagnosis of infection, but not necessarily other parenchymal details. So if the baby was not improving, like in this case, and then the MRI gives you the extra detail that there is actually a brain abscess. These are just images from a baby with candida septicemia, neurocandidiasis. You see the tiny abscesses like kind of throughout the brain, with preference for the gray-white matter differentiation or the junction. In terms of hemorrhage, we're going to see hemorrhage as a hyperechoic material when it's intraparenchymal. We can also see it just as anechoic or hypoechoic when it's mostly fluid in the extraaxial space. This is a 4-month-old with non-accidental trauma, and you see that enlargement that corresponds to a subdural hemorrhage. This is a baby with hemophilia. Do the ultrasound. This is a linear probe. This is a coronal image. And you see that large hemorrhage kind of lifting up the entire temporal lobe, and also pushing the left hemisphere into the right with causing subfalcine and uncal herniation. This is a sagittal image that corresponds to the same baby at the same time. This is how it looks in CT, and just a reminder of how the herniation patterns work inside the brain. This is multi-compartmental hemorrhage. Again, linear probe. We don't even make it to look at the lateral ventricles. And still we see that there is blood that is both kind of intraparenchymal, but also extending into the extraaxial spaces. This is how it looks on the CT. That is a look that is more familiar to us. And we see again that there is intraparenchymal hemorrhage, but there is also subarachnoid component and intraventricular component. In terms of congenital malformations, again, these are coronal and sagittal images. We see that anechoic structure posteriorly. And then when we put color Doppler on it, we know that it's a vein of Galen malformation. Or if you interrogate with a duplex, you do see that there is arterial and venous flow. A better name, but that I don't get used to it yet, is median prosencephalic AV fistula. We know it's not a vein, and we know it's not a malformation. It's just an AV fistula. This is a baby with a myelomeningocele, and you see that colpocephalic configuration, typical of the Chiari-2 malformation, the small posterior fossa, the crowded posterior fossa that we see when we go through the mastoid fontanelle. Other baby, abnormal prenatal ultrasound, present to us. We see the ventriculomegaly, kind of colpocephalic configuration. And when we see the posterior fossa, it's not only small, but there is an abnormal communication between the cisterna magna and the fourth ventricle. So if I show you that same picture, but I reorient it to be in the same way that we see axial CT, it looks very, very similar to the axial CT and the same configuration of the ventricles in a Dandy-Walker malformation. This is a case of holoprosencephaly. Again, the ultrasound in coronal gives you the same information that the MRI would give you. And again, just use as a screening pattern to move on to the MRI. This is a case in that they sent me, and they just wanted to know if what was the content of this malformation, of this lesion that you see. They send me ultrasound images, so you see it here. You see that there is also not only a meningocele where we see the septations, but there is no actually brain parenchyma going into it, and we see the ventriculomegaly with absent cavum septum pellucidum and what looks like an abnormal communication of the lateral ventricle. So this is in the septo-optic dysplasia spectrum, but a baby went to surgery knowing that it was just a meningocele for the occipital defect. This is a 2-week-old, and you see the big bump here, just kind of closing up to talking about bumps. And this is a typical presentation and the typical ultrasound findings of a cephalohematoma. It doesn't require any extra imaging. It will kind of resolve with time. This is a 14-year-old with a lump. We did the ultrasound, and in this case, different than the previous case of cephalohematoma. Well, first, this is a 14-year-old, but also you see that this is a solid lesion. It has some flow through it. It has some cystic components, but it also has a scalloping of the skull, of the bone underneath. So this patient does require extra imaging with CT. We've seen the same findings with some enhancing tissue, and this ended up being a diagnosis of LCH. Last one I'm going to show you. They sent me these pictures also for a telemedicine case, and they wanted to know what I thought from this, and I'm like, well, I don't see that well the brain, but I don't see ventriculomegaly either. I think these are coronal images. I was a little confused, I'm not going to lie about this case. But then they sent me a picture, and I realized that what we're imaging is not the brain itself, but just the mass that was outside. So this is kind of like the typical appearance of a suture-associated dermoid, in the fontanelle in this case, and that it doesn't have any intracranial extension. So I'm going to stop right here. I'm just going to tell you that again, the brain ultrasound can be used for as long as the anterior fontanelle is open. And we can determine the shape and the size of the ventricles. We can determine acute changes. And more importantly, we can use it also to screen in these babies who needs a CT and an MR. What kind of thing can we diagnose? Hemorrhage, infection, congenital malformations, and of course, intracranial extension of superficial lesions. With that, I thank you for your attention, and I leave you with my email in case you have any questions. I see you. See you soon. Thank you.